Our students, Assalamu alaikum. I would like to talk about the last part of Class 2 Division 1 malocclusion. I'm going to talk about the management of such type of malocclusion. Before we are going to discuss the general protocol that should be followed during the treatment of Class 2 Division 1 malocclusion, it is very important to keep in our minds the following important factors. First of these factors, that the patient commonly is associated with the convex facial profile. That is mean that when we taking lateral cephalometric for the patient, the A and B angle most commonly is more than 4 degrees. That is commonly due to protrusion of the upper jaw or retrusion of the lower jaw or combination of both. In addition to that, the patient most commonly associated with a protrusion of the upper incisors. That is why it is called the Class 2 Division 1 malocclusion. In addition, we can see that the patient is associated either with incompetent lips or potentially competent lips. That is due to protrusion of the upper jaw or protrusion of the incisors, and sometimes due to short lips. Also, we can see the patient having Class 2 canine and molar relationships, and most commonly in such type of patient we can see is associated with deep overbite, either deep incomplete overbite or deep traumatic overbite. So in general, are these factors are enough to undergo or to achieve a treatment for Class 2 Division 1 malocclusions? Some type of these factors are very important. As example, when the upper incisors are protruded forward, they are most commonly affected by trauma than patient when the upper incisors are upright or having mild increase within the amount of overjet. Also, when the patient having deep overbite or when the lower incisors touch the palatal mucosa behind the cingulum of the upper incisors, they are affecting the long duration or the longevity or the long-term prognosis of the upper incisors. So those both factors, either protrusion of the upper incisors or deep overbite, both of those factors are very important, or they are enough to necessitate a treatment for Class 2 Division 1 malocclusion. In addition to that, especially when they are combined with the other factors. So, as a Class 2 Division 1 malocclusion is contributed by different etiological factors, so such type of malocclusion can be treated by different possibilities, starting with simple means. So in case when the patient having a Class 1 skeletal pattern, or when the patient having a mild Class 2 skeletal pattern but the upper incisors are proclined, or when the patient having mild increase within the amount of overjet and there is enough space for their reduction, so we can use a removable appliance by utilized Hawley arch for the reduction of the overjet. The second most important approach for the management of Class 2 Division 1 malocclusion is by using functional appliance, or sometimes it can be called intraoral orthopedic appliance, because these types of appliances will assess the relation of the jaw bases, so at the end of the treatment we can improve the relation of the bones as well as improve the aesthetic and the profile of the patient. These types of appliances are either removable or fixed, and they are different types from these. The first twin block appliance and monoblock appliance, in addition to bite jumper appliance, in addition to difference appliances. Most of these appliances, they are uncomfortable and complex appliances, so these appliances need more cooperative and compliant patient. These appliances, to be effective, should be indicated for patient associated with a mild to moderate skeletal discrepancy in sagittal plane due to mandibular retrusion rather than the maxillary protrusion. Also, they are indicated for more growing patient and well favorable growth pattern. Also, when the patient is more cooperative and compliant patient, as we said, these appliances are more complex to achieve more continuous wearing of these appliances. You can see in this patient that the patient is associated with mild skeletal pattern, so this patient is indicated for functional or intraoral functional appliance to correct the underlying skeletal discrepancy, and later on is followed by fixed appliance to interdigitate or to increase the intercuspation between the upper and the lower arch, and at the end of the treatment we can achieving a class 1 relation of the dentition. The other decision for the management of class 2 division 1 malocclusion is by utilizing extraoral traction, or sometimes it's called extraoral headgears or extraoral anchorage. Such type of orthopedic appliances, they are most commonly indicated when the patient is associated with mild to moderate class 2 skeletal pattern. That is mean the A and B angle is more than 4 degrees. But here the severity of the A and B angle is due to maxillary protrusion rather than the mandibular retrusion. In general, there are different types of these headgears. They are called parietal pull headgear or cervical pull headgear, and in addition to that, the other type it's called occipital pull headgear. Such type of appliances, to be effective, they are indicated when the patient is growing or when the patient age is between 9 to 12 years old. Also when the patient having more favorable growth pattern. As these type of appliances, they are complex and difficult to be weared by the patient, so the patient should be well cooperative and compliant patient. Such type of appliances, they can give heavy intermittent type of force to give remodeling of the bone, and to be effective they should be weared between 12 to 16 hours per day. In addition to that, from their shape or from their direction of force, as you see here in this arrow, they can give retrusion of the upper jaw backward, or can be used at least they are retard or stop the growth of the maxilla forward to give a chance for mandibular growth. So such type of appliances, they are similar to the previous functional appliance, but here they are indicated when the maxillary growth is more forward rather than the mandibular growth backward. When the patient is unable or uncooperative for wearing either the removable orthodontic appliance or the functional appliance. Also when the patient is associated with moderate skeletal discrepancy in sagittal plane. In addition to that, when the patient is during or passing the growth potential. Such type of patient is indicated for using fixed orthodontic appliance by a method which is called orthodontic camouflage treatment. So what we mean by camouflage treatment? It means the correction of the dentition by tooth movement rather than the correction of the underlying skeletal pattern. In other words, it means the compensation of the underlying skeletal pattern discrepancy by the correction of the dentition to achieve at the end of treatment class 1 normal relation of the dentition. As you see here in such patient, you can see that the patient is associated with mild to moderate skeletal pattern. Also the amount of overjet is mild to moderate increase. Also you can see that the patient is growing due to the stature of the upper canine. And the patient may be unable for wearing functional orthodontic appliances, so he or she indicated for wearing the fixed orthodontic appliances. So at the end of treatment we can see that the patient is having a class 1 relation of the dentition, so the incisors are class 1, the canine is a class 1, and the molars also they are class 1. But when we take lateral cephalometric at the end of treatment for such patient, we can see that the A and B angle is remain mildly increased more than 4 degrees. The last treatment decision for the management of class 2 division 1 is the orthognathic surgery. Such approach most commonly is indicated for adult cases when they are associated with severe sagittal skeletal discrepancy. Also when they are associated with severe gummy smile, as well as they are associated with unfavorable growth pattern. So in general, as a conclusion for the management of class 2 division 1 malocclusion, we should consider the following factors in our minds before treatment of such type of malocclusion. First of these factors is the severity of the skeletal pattern in all 3 planes. Second is the cooperation of the patient, whether the patient is cooperative or uncooperative patient. The third factor is the soft tissue relation, as at the end of the treatment we should achieving normal soft tissue relation or normal anterior oral seal to achieving stability of the incisor relation. Otherwise either accept the case or need a permanent retention, or there is a relapse of the case. The fourth factor, which is most important, is the growth potential of the patient, as well as the growth pattern, whether the patient is having favorable or unfavorable growth pattern. So the general protocol that should be followed for the treatments of class 2 division 1 and according to these forementioned factors is the following. First is the removable orthodontic appliance. Second is the functional appliance. Third is the by using extraoral orthopedic appliance or extraoral traction. The fourth by using fixed appliance, and fifth by using orthognathic surgery. Wassalamu alaikum wa rahmatullahi wa barakatuh.